Hi, I'm Lee Hammond from the Central Queensland Wide Bay and Sunshine Coast PHN, and I'm here today to introduce you to a statewide project strengthening the health assessment response for children and young people in care, and let you know how that is going in the Maryborough and Hervey Bay area. Before I commence this session, I would like to acknowledge the traditional owners of the land we meet across today, and in particular the Butchulla people, land and sea, who are the custodians for the Maryborough and Hervey Bay area. Now, to get just a little bit of a history of this project. This project came about in response to a widespread perception that the existing child protection system in Queensland was failing vulnerable children and their families. So the Honourable Tim Carmody QC was appointed to review the progress of recommendations, both the 1999 Commission of Inquiry and the 2004 Crime and Misconduct Commission of Inquiry, and make recommendations. The final report, Taking Responsibility, a Roadmap for Queensland Child Protection, found that the perception of a system under stress was justified. Over the past decade, child protection intakes had tripled, rates of Aboriginal and Torres Strait Islander children in out-of-home care had tripled, and the total number of children in care had more than doubled. In 2012, the report was finalised, and in 2013, all 121 recommendations were accepted by the Queensland Government. In 2017, the Brisbane South Primary Health Network successfully tendered for the Strengthening Health Assessment Response for Children and Young People in Alternate Care. This was a Queensland-wide project, and recommendation 7.7 of the report. In 2018, the project commenced across pilot sites. Maryborough was included as one of these sites. Each pilot site is attached to a PHN across Queensland. So what did we know? We knew that children in care were likely to have poorer health than their peers. We also knew that child safety found it challenging to navigate the health system, that children in care may not be accessing the full range of options within the health system, and that there was no established health pathway for children in care and their carers. Case coordination was limited between the health system and the statutory child protection system. Gaps in the primary health system regarding the importance of a comprehensive assessment to identify the needs of the child, the importance of streamlining and coordinating referral to avoid escalation of behaviours, deterioration of health, impact on placement stability. The impact of complex shared care relationship between the child safety officer and the carer, and also understanding of the impact of how to work with trauma. There was also a national clinical assessment framework for children in care that had been developed by the Australian government in 2011. This we regarded as very useful to roll out this project and introduce people to and also find out if the stakeholders working with children in care were familiar with this framework. So the National Clinical Assessment Framework looks at the different age group assessments and looks at the physical, developmental, psychosocial and mental health domains, and looks at the development of a health management plan and personal health record. There is also the identification of a healthcare coordinator as one of the elements. This is something we have found difficult in our project, but I'll refer to that later. It identifies three main assessment types. So a preliminary health check, which is done within 30 days of the child entering care, and that will address immediate health concerns. A comprehensive health and developmental assessment within 90 days of a children entering care. and that will address more serious issues and also involve uh, other health providers um, around mental health, allied health, etc. So what did we want to achieve? We wanted to improve the access, timeliness and quality of health assessments for children entering alternate care. Also, the improvement in GPs, primary health and specialist staff knowledge and understanding about working with children in alternate care, particularly the National Clinical Assessment Framework. We also wanted to improve the primary health and child safety integration and the case coordination. So to begin the project in Maryborough, we held a couple of months of local stakeholder engagement. Some of those stakeholders, of course, child safety, Churches of Christ, they are the carer organisation in the Maryborough and Hervey Bay area, the carers and the parents, general practice. Galangor Dewalami is the Aboriginal Medical Service in Maryborough and Hervey Bay, the Queensland Health Services, Centrecare, Evolve, Headspace, Youth Justice, the Central Queensland Indigenous Development Group, Wide Bay Women's Health Centre, University of Southern Queensland, Sunshine Coast, Education Department. So, and other stakeholders that we came across that just had an interest in this area or had their finger on some touch point of this area. Education Day was held in March 2019, and these are some of the local gaps and challenges that were discussed on that day that came out of the stakeholder report. So for general practice, health and child safety, they all recognised that limited family medical history was available. For the health services, the general practice and health, there was also inadequate MBS remuneration for the time spent on these assessments with children. There was a lack of general practitioners with special interest in children with complex needs, and the availability of local services to refer complex cases to. For child safety, they also recognised there was limited family medical history available. And for them, it was really difficult because they were the ones that were trying to dig this up or investigate and identify what was available. The turnover of child safety officers and placement changes also was a challenge in trying to define the medical history of a child and have it available with the Medicare card and child registration, birth certificate, all those sorts of things coming into the medical history. The availability of local services, once again, and there was very much a confusion of the case coordination roles amongst all stakeholders. The foster and support agency, they felt that there was a lack of trauma-informed practitioners, and also the coordination of service referrals was difficult, and navigating the health system was extremely hard for them. Carers also found it difficult with the lack of documentation around medical history and access to medical documentation, the costs of healthcare that might crop up, and also confusion of case coordination roles. So following this stakeholder engagement, we developed a community of practice. This commenced on the 23rd of April in 2019, and this group meets monthly. It consists of the stakeholders that we discussed earlier and includes the paediatrician, the Queensland Health paediatrician, our GP on the board, who is also the GPLO for PHN and sees children in care regularly, representative from the Aboriginal Medical Service, from Child Safety, from Churches of Christ, from CQID, from Education, from Evolve, Centrecare, Headspace. They are all extremely committed to this project. As part of one of the actions of the community of practice, we developed a localised health pathway, and we are currently looking at case study tracking of children entering the child safety system to see how that pathway is working. We are identifying further gaps through the process of trialling and testing that pathway, and we are also developing partnership agreements for the people that sit around that table. With the Aboriginal Medical Service, they have an Indigenous health pathway that is very child-centred, and it aligns really, really well with the health pathway we have developed within the community of practice. It's a very child-centred model and is used by the local Galangor Duwalami, and it involves the 715 health check for Indigenous people. Galangor Duwalami also ensure that children in out-of-home care are given a priority and will be seen even if waiting lists are in place. So this is the localised health pathway that we have developed through the community of practice. As you will see, when a child enters child safety, there are certain actions taking place. When the CSO is appointed and the order application is in, the case plan is then commenced and health-related data is collected. This is where it is a real struggle for them trying to get the medical history that they need to pass on to the next stage. The next stage where you will see where the 2 is the child Churches of Christ and the carers. So from child safety to there, a GP letter, the authority to treat letter, is sent, and also the child information form with as much of the child medical history as possible on it. And there is also the authority to treat letter. It then moves to the National Clinical Assessment Framework, as we spoke about earlier. So firstly, the preliminary health check at 30 days, the comprehensive health check at 90 days, and then the ongoing mentoring that will take place. At the side here, I have the screening tools. So we look at the screening tools for children aged 0 to 24 months, children aged 2 to 9 years, children 9 to 11, and then children 12 years and over in the initial preliminary health check, and then following on their more complex screening tools for the comprehensive health check. Information sharing, training and education is a large part of this localised health pathway, and it is provided to all stakeholders across the pathway. So the further gaps that we did note around the collection and documentation of health information at the Child Safety Service Centre point. Now, that can be, as I mentioned previously, because there may be no registration of the birth, there may be no birth certificate, so therefore there's no Medicare card. And that can take up to 18 weeks to access all of those things if the process has to be put in place, which means that the 30-day health information, health assessment is difficult to maintain. Information to carers has been very sporadic. We're trying to tighten that up through our trial and test process. GPs have no standard way to report back to child safety and other relevant stakeholders. Our GP on our community of practice and our paediatrician on the community of practice are currently working together to look at some sort of system to feed that back. Other current actions that we have going are continue with the community of practice, continue with case study data collection and looking at those gaps, challenges and needs within the meeting points of the health pathway. We are looking at development of an education package. This session today is the first of a series of sessions that we are putting together, and they will be available on the PHN YouTube page for anyone to access. We continue to monitor and promote the out-of-home care information on the digital health pathway. The PHN digital health pathway is something that GPs and health professionals can use to get referral information for out-of-home care children's needs, and also certain amount of tools to develop up their practice and ensure the trauma informed care is looked at. We will be looking at trauma informed care quite closely in the future. And we continue to monitor and embed the localised health pathway. So that's all for my session today. It was a brief introduction to this project. We will be continuing with more sessions. The next one will be either one of how child safety, the process in the health pathway works, or we will also be talking to the GP about how the first assessment, like how they do the assessments, what forms are used, what happens with the children, how they develop a health management plan. So for any further information you'd like meantime, please contact me, Lee Hammond, on 042 151 6087, or my email address is lhammond@ourphn.org.au. I look forward to hearing from you and talking more about this project. Thank you very much for your time today.